rotator cuff repairs, and how many of these are really needed? Is the surgery something that is overdone? Is therapy actually something that can be beneficial? So, the rotator cuff is an important group of muscles with respect to shoulder pain. Essentially, it's not just one muscle. You hear rotator cuff, people think one muscle. You hear people say rotator cuff and all sorts of different things. But it's actually 4 muscles. And I'm going to try and see if I can show you something on the screen. We'll see if it works or not. Bring my iPad up here. But you can see my little man here. And you can see see how good I am at manipulating him. But you can see the overall anatomy of the shoulder from behind. And what I'm going to do is I'm going to take some of those things away, and I'll show you what the rotator cuff looks like. So let's see if I can manage to do that well. Alrighty, let's see. So now I've taken back some of those muscles, and we can see how there's all sorts of little muscles that sit under the shoulder. Okay, and what I'm going to do is I'm going to bring that back up on screen, and you can see the different rotator cuff muscles. So here's one. That's the supraspinatus. Here's another one. The teres major. And we can also see the subscapularis, and I think I've managed to take one of them completely out of the picture. Actually, nope. Here it is. Here's the other one. That's the supraspinatus muscle. So what you can see about those rotator cuff muscles, and I was seeing if I could actually share the screen from my iPad, but I haven't worked out a way to do that, is that the rotator cuff muscles are relatively small. And as such, people don't necessarily think that they have hugely important function. But basically, the way that they work is they are functional throughout every movement you do. So here's the ball in the socket. When your arm moves up and down and the ball moves in the socket, we need to ensure that that ball moves correctly. So when you come up, that rotator cuff needs to function well so that the ball doesn't translate too much in the socket and doesn't get and irritation doesn't occur. So when someone has a tear in the rotator cuff, and we understand that these muscles are important, people think that they need to have it fixed. The idea that something is broken and something needs to be fixed. And that's very typical. We understand that about our cars, our washing machines, and whatever else. But is this really the case in the shoulder? How important is it to fix a rotator cuff that's torn? And, being in Huntsville, lots of engineers, there's a want to fix things. There's a want to make things better. And I get that. I'm married to an engineer. But is this always the case? Well, we're going to look at a few pieces of research and just a few simple statistics that might make us question this view. So we know that as someone moves into their 50s, that 2 times as many people have rotator cuff tears that are not symptomatic as compared to those who have tears that are symptomatic. So we know that there's a lot of people out there who have tears and they may never, ever know anything about them. They may never give them any symptoms of pain. So if you have shoulder pain and you get an MRI and it shows a rotator cuff tear, does that mean that we should immediately assume that that's the cause of the problem or that it's new? No, it could be something that's been around for a long time and being completely pain-free. Now, the other thing that we know is that 40% of rotator cuff repairs fail to heal. But the people who have that are actually happy with their outcome, both in terms of pain and function. So you've had a rotator cuff repair because you've got shoulder pain and you've got a rotator cuff tear that the doctor thinks needs to be repaired. 40% of the people will find that repair will actually not heal. It may re-tear to some degree, it may just not heal, but it didn't, it makes you question if they have good outcomes. Was that surgery actually needed in the first place? So, or if the surgery was needed and the repair actually didn't heal, what is the mechanism by which you actually saw the pain relief and saw the functional improvements? So it makes us start to think, do people really need to have these repairs as much? Who are the right patients that need to? And I think, orthopedic surgeons are in a difficult position here. And I know some great ones both locally and further afield. And I think they have their work cut out in terms of working out who should be having them and who shouldn't. But let's look at the idea of how we have rotator cuff tears. We know that people have them and don't have any symptoms from them. It's probably part of the aging process. So let's think of, there's two types essentially. There's what we would call a degenerative tear and a traumatic tear. So something that's just happened over time, maybe part of aging. And then we've got an acute or traumatic tear, something where we think that it's happened due to a particular trauma. So when we look at a chronic tear, a degenerative tear, even one that is full thickness, so a full thickness rotator cuff tear, meaning it's going across the tendon, through the tendon of one of those rotator cuff muscles, 75% of those people will actually do very well with physical therapy as compared to surgery. So a significant portion of those people don't have to have surgery immediately. It's worth them actually trying physical therapy and conservative therapy first of all. So that's the more typical tear that we see a lot of, and I've seen lots of them do very well with therapy. Then you've got the idea of the acute, more traumatic tear, where someone's had an injury, their shoulder is hurt, they go to the doctor, they get an MRI scan, and it shows what is thought to be a fresh rotator cuff tear. So the big concern here is, well, if you do conservative therapy, if we leave it too long, how effective will the surgery be? How easy will the repair be? And there is some validity to that. The longer you leave a tear, the bigger, especially in the case of a full thickness tear, the bigger it's going to get. So 82% of full thickness rotator cuff tears are actually going to increase in size if you don't repair them, versus 26% of partial tears. So those tears are going to increase in size. But again, is that a big deal? Is it a big deal that the tissue quality gets less? So we get a fat infiltrating into the cells, we get a breakdown of the collagen. So that tendon, that rotator cuff tendon, is less structurally sound and perhaps a little bit more difficult to repair. And this is a huge debate amongst orthopedics surgeons and people who work in orthopedics. So we actually, if you look at the research, there's recommendations of waiting anything from 4 months to 24 months to having the surgery. So there's a huge debate over, even with an acute tear where the person feels they know that this happened and it's new, there's a big debate over whether they should wait or shouldn't wait. Well, if you wait, what should you do? I think at the end of the day, trying some conservative therapy is definitely a reasonable approach in those cases as well. Now, that's not taking anything away from the orthopedic surgeon. You've got to find an orthopedic surgeon that you really like, and not just like, but trust, that you feel that they're really giving you the most up-to-date information around around rotator cuffs and around the surgery that they offer. So I think, with a good decision from a surgeon to allow you to try conservative therapy and seeing a therapist who's doing the right things for you, I think that it's definitely worth trying to treat a rotator cuff tear conservatively with physical therapy, even if it is an acute traumatic one versus a more degenerative chronic one. And in terms of what the therapy should look like, because I mean, people have been to physical therapy, people have tried different things, and they have an idea of what they think it should be. There are things that go on within healthcare, some of which are well-founded, well-researched, and good quality treatments. And there are things that go on that really have been shown to be less beneficial for you. So probably the best type of treatment that we have conservatively for a rotator cuff tear is therapeutic exercise. So the big difference between therapeutic exercise and general exercise is the purpose of this exercise is to give you relief of your problem. So in the first case, you've got a painful shoulder. Well, one of the best type of exercises that we can use for painful shoulders are isometric exercises. And they don't have to be weak, woolly exercises. They can be quite firm. So, an example of an isometric exercise that we might do for someone with a rotator cuff problem is what we call belly press, where you put your hand here and you pull into your belly for, say, 5 seconds, and you pull pretty firmly. And, depending on the exact nature of your rotator cuff problem, these isometrics can give significant pain relief. Now, that's actually the case with people who've got rotator cuff tendonitis, or rotator cuff tendinopathy, as we now call it. I had someone the other day who probably had a small rotator cuff tendinopathy. They came into the clinic and gave her some isometrics and went through them. She felt a little bit better when she was doing them here. And then she went home and messaged me. She's like, wow, they're like magic. They really are pain-killing exercises. So there really is something to starting off with isometric exercises for pain relief. And then as pain settles, we can move on to what we call isotonic exercises, which means that we're taking our arm, our muscle, through a range of motion against a consistent load. So a great example for the rotator cuff might be, if I stand back here, supporting my arm on a tabletop or a counter or something like that with a weight and rotating it up and down really slowly. Now, muscle tendons don't like heavy load and velocity, but they like to be loaded. They do like a heavy load. So we can apply a heavy load slowly. The muscle and the tendon can usually adapt, and that's where we don't just do it without any thought process to it. We think about pain. So what level of pain is reasonable? We typically use a 0 to 2, 0 to 3 pain level as being a reasonable to exercise with, as long as it doesn't cause you to flare up for more than 24 hours. So various isotonic exercises are a good place to go to start to build strength and get continued pain relief. And I guess I'll say about the heavy load, and I'll compare that with traditionally when people look up about rotator cuff or shoulders, they may be getting a resistance band, and they may just be doing kind of this down here with a resistance band. Now that may be well and good for someone who's acutely painful, but for most people, once pain is settled, and like I say, those isotonic exercises are great for pain relief. But those band exercises do not put any significant load on the muscle and really don't make a great change to the muscle strength. So I very rarely use the bands down there now, as compared to what I did probably 5 or 10 years ago. Instead, we want to put heavier load on, so we can use dumbbells. We can use barbells, we can use kettlebells, put a heavier load through the shoulder, through that rotator cuff with a slow velocity. And then the other thing that's true of that exercise, the one I showed you just there, where the arm's supported and you're rotating versus doing the arm by your side, is we want the rotator cuff muscle to be functional in different places of elevation. We don't want the rotator cuff muscle just to be functional down here. We want the rotator cuff muscle to be functional up here so that it stabilizes us in every different place. So we don't want to be trying to lift something out of a cupboard and get pain because we've only been working at rotator cuff strength down by our side. So it's very important to do the right exercises. And there are other things within therapy that people try and use. Great examples are electric stimulation and ultrasound, and really in most uses of that we're finding that at the most they're a placebo. So it's not to say you won't feel a relief, but your relief might be quite limited, might quite short-lived, maybe an hour or two, and not really have any dramatic effect on the long-term recovery of your problem. So actually here at PhysioWorks, I don't use I don't have an ultrasound unit, because, like I say, there's not much. I don't think it's great value for you, the patient. And for electric stimulation, you don't need to have some fancy, big, expensive unit applied to you in the therapy clinic. It can be as simple as we show you how to use a TENS unit, and you actually can buy a TENS unit for $30 off Amazon and get a very similar placebo effect. So there are things that you can do that are good and that are great, which I think exercise is one of them. And then you can do things that are probably have been shown to be more placebo-based, and it's one to decide for yourself whether you think it's worth you doing or not. And then there are other things that are really not so well researched out there, that there's a lot more debate about, and as such, it's questionable whether you should try it or shouldn't, but probably they shouldn't be the first course treatments, the most important treatment for you. So an example of that would be dry needling. I'm accredited a dry needle, but really I don't dry needle anymore because the research to me doesn't really back its use very well. And I think people who say they get benefit from it, perhaps some of them do, but we just don't know who gets more benefit than and who actually should be applied on. So but it's something that's out there. It's something that's legal for physical therapists to use. But again, I don't think it should be a first-line treatment for a rotator cuff problem. First thing should be pain relief, and like I say, isometric exercises are great for that, and then progressing on to isotonic exercises and progressing through heavier loading so that the muscle is resilient and the muscle has better control. So it's a challenge for both surgeon to decide which patients should or shouldn't have surgery, and it's a challenge for a therapist to make sure that they're progressing patients correctly and using the best treatment available, and and encouraging the patient in the right way to progress. So I've got a couple more minutes before I've got a patient, and does anyone have any questions? I see that it shows there's one person looking online. I know one of my friends, Donna, was looking earlier. If you've got any questions, I'll stay on for a couple more minutes, and feel free to write them in the comments box. And if you're watching this video after the fact, feel free to either add a comment to the video with a question, or to send me a Facebook message, or you can send me an email to andrew.walker@physioworkshsv.com, and I'll be happy to try and answer it and give you some information. And if you've got a shoulder problem, do feel free to reach out, and we can get you in here for a screening examination, just a 20-minute look at the shoulder and get an idea of whether it's something that physical therapy could help, or whether actually it's something you should be consulting with an orthopedic surgeon about. And I'm not going to keep someone under my care who needs to have that orthopedic opinion. So if you've got any questions about that, I'd be happy to talk. All right. Any other questions? And I'll probably turn this into a blog at some point. It just takes a little bit of time to prepare those blogs and to edit them, and make sure that they're not too technical, and make sure they're something that you can read and get into. So again, you can contact me on 256-529-7395, or andrew.walker@physioworkshsv.com, or you can get in contact with me via Facebook, via the business page, PhysioWorks Sports and Wellness Facebook page. And I'm going to sign off and get to my next patient. You all have a good day, and I'll speak to you all soon.